Welcome. Today we're going to talk about, can you really predict a heart attack? How many people have not heard the story about Tim Russert? It's a classic story. He tried to prevent his heart attack. He tried to predict it. He went to his doc and he said, I'm having some trouble with a few things. I'm getting a little bit heavier. They took a cholesterol test. They did a stress test. He passed it with flying colors. And a few weeks later, he died from a heart attack. I wrote a whole book about people thinking that they're going to get a stress test and it's going to predict their heart attack. Does it really do it? No. Heart attacks are the number one cause of death worldwide. Strokes, usually number 2 or number 3. And when you put that together, strokes with Alzheimer's, they're the number one cause of permanent disability. And they're really caused by the same root cause: poor metabolic health. And it's not funny. It's a disaster that people are looking down the wrong pike, looking at the wrong things to see if they're at risk for a heart attack or stroke or Alzheimer's or blindness or kidney disease, or for men, even erectile dysfunction. Now, believe it or not, there are ways to know if you're at risk for a heart attack. We're going to give you some of the best tools ever. And by the way, if you would like to get a copy of that book, there are going to be some ways where you can actually access that book for free. You can begin to understand if you're at risk for heart attack. And, up until recently, it cost usually several $100, often a couple of $1,000 or more. We're going to discuss some tests and some ways to access those tests today that are just much more accessible, much more affordable. So, Jesus, you ready to get started?
Absolutely. Thank you so much for joining us today, guys. We have a good show. First of all, I wanted to address the question. So can you really predict a heart attack? Do you have an answer for that, Dr. Brewer? What do you think?
I've got an answer, but it'll be one of those answers you don't like.
Here you go again. It always depends, huh?
It's a tragedy that right now we live in a world where you turn 60 years old and you're walking through the valley of the shadow of death. You could have a heart attack or a stroke and die. And half the people that do have a heart attack, how do they find out? Instant death, instant sudden cardiac death. That's just not a great place to be if you're 60 years old. And guess what? I'm 67. I'll be 68 in a few months. And I'm not so worried about it. Am I just goofy? Am I denying it? No. I know some things that most people don't know about the risks for heart attack, for stroke, for all those things that we're talking about. Again, I can't help but share while we're talking about this. I was just at Dave Feldman's event, the COSI group, Collaborative Scientists meeting in Vegas this week. And we had the premiere of the new movie, Cholesterol Code. When it comes out, you got to see it. This is not just a YouTube documentary. This is a Hollywood level. It was a Hollywood level premiere, and they're negotiating distribution rights with Netflix right now. So this is going to be something that really starts to get that message out there. And I hate to say it, but it's true, and I can't help but say it. A lot of the comments were that, Peter Attia is not going to like this. And Peter's going to do fine as people begin to see the messages that are coming out. The new longevity study, longitudinal study for the lean mass hyperresponders came out, and that's part of that movie as well. And that'll be coming out in publication. The evidence is just piling up. deeper and deeper and deeper. And now that I set that context, I'm going to answer your question. Yes.
Finally.
It's not LDL. It's certainly not a stress test. It's metabolic health. And there are ways to evaluate metabolic health. So I know that took a lot longer than you were looking for, but that's your problem. You're working with me.
Well, and probably if you really want to know when and how are you going to have a heart attack, or when and how are you going to die, probably a psychic will have a better chance to find that answer than a doctor. We're always talking about risk. What are the chances of something happening? And that can change. You can change your destiny if you change your lifestyle. And that's but the first step is to realize this is not just a cholesterol problem. This is a metabolic health problem. So that leads me to a small piece of advertisement. Let me put this on stage. We have a product that can help you out to find that risk at home, but this is not a sales pitch. We want to provide you with the evidence first. So let's look at what's out there. What are the tools that are out there to find out if you're going to have a heart attack, or, well, if you're going to die of a heart attack?
Well,
What
so
about
now
Framingham?
if you're going to ask me a question, I may not go where you want to go, Jesus. I'm going to say it's not a sales pitch at all, or it is a sales pitch, depending on how you want to interpret it. From my perspective, I couldn't be more excited. It's finally here. When I was faculty at Hopkins 30 years ago, a little bit more than that, I was an epidemiologist there. We were looking at the causes of early death, disability. Many of us kept saying the same thing. If we could only figure out a way to make metabolic health part of the agenda, the public health agenda, get people to talking about it, figure out a way to get people to make it available for people to evaluate their own metabolic disease and their own metabolic health, and then start helping them understand what to do about it, it would be the biggest thing that we could impact in terms of the health of the public. So I'm excited. We're getting there. We've got a box. We're making that available now, and yep, you can see that as a sales pitch. I'm seeing that. I will tell you this. For those of you that see it as a sales pitch, we're not making money on that box. It depends on how you do accounting on whether we actually lose money or make money, because there's just so many different components on it. Now, in terms of getting into the different components, there's about 30 different bioindicators of healthy longevity and metabolic health that are included here. In addition, then there's an hour-long review with a health coach consultant that's already taken all of your readings and said, how do these fit in terms of our formula, our protocols, our risk assessment? So, Jesus, why don't you go into the next slide, and why don't you answer your question about Framingham?
So if you go to your doctor, they will run a calculation based on this. It's a good study. I will not say it's a bad study. On paper, it looks like a good study. It's based on a bunch of people on a city called Framingham, that's near Boston, and they tracked them for years and sent some questionnaires and got some answers. And turns out they're using this calculator to see if people has a high cholesterol, high LDL cholesterol, they might have a higher risk of having a heart attack. That's what this is based on. Unfortunately, it has a lot of flaws on it. Somebody says that if you're a white Bostonian, maybe this works for you. But other than that, there are a couple of things that don't necessarily match. And Framingham is actually not necessarily being updated right now. So, but this is what's being used right now outside of YouTube, just on a regular medical consult. This is what you're going to get for predicting heart attacks. Oh, we lost your audio, Dr. Brewer. Want to fix that? I can
How's
keep
that?
on. Well, yeah.
How's that?
Good.
So most docs, basically, you know, they're docs are human beings. They're busy too. They want a shortcut when they can. And most docs are going to say, okay, well, let's just do a cholesterol test. Cholesterol is part of a full Framingham assessment. But again, all of the standards committees, everybody else, the American Heart Association, American Diabetes Association, internal medicine boards have all said, look, doctors are shortcutting the process. It's sitting down and having a discussion about multiple bioindicators, multiple risk factors. It's not just doing an LDL cholesterol and getting a stress test.
Yeah.
And in fact, they've really focused on stress tests. They've all these standards committees, you know, even if you talk to your doctor and your doctor's talking about getting a stress test, even your doctors, the majority of them are avoiding and not listening to their own standards committees. Their own standards committees are saying over half of these stress tests don't have an indication. They're not appropriate. They're not helpful. And they're not giving you the information that you need. But they are, well, I can't help but say this, but they are helping pay for mortgages on clinics and putting doctors' kids through college.
Yep, for sure. And just to give some credit to Framingham, they do include weight, they do include smoking, which are risk factors to be considered. The problem is it's not necessarily considering metabolic health, which is the main driver. And in regards to stress test, there is a place for stress test if you want to know your fitness status, part of your VO2 max and other stuff. Even if you want to identify if you have some rhythm issues, not necessarily blood flow issues, but just rhythm issues, it can give you some hints, but it's not necessarily going to predict if you're going to actually have a heart attack. And the problem is not so much if you don't pass the stress test. The problem is if you pass the stress test, that doesn't mean that you're off the hook. That's the problem.
So before you go back to stress tests for a minute, and let me add a couple of things. As you said, yes, stress tests tells you about endurance, and endurance is an important bioindicator. One, again, out of over 30 that we can look at. Another thing to think about is how important is that one? Yes, there is some importance there. The ability to do heavy exertional activity, that's an important part, but it's only a small part of dozens of bioindicators that we really need to know in order to look at your risk of heart attack. The stress test is what many of us in this business or this market or this field of medicine would call a flow study. What do we mean by flow study? It measures flow. See, what the doctor's looking for is if you start to get some abnormalities on your EKG rhythm strip. And that will happen if you've got 50% blockage in the artery itself, the arteries that go to the heart. Again, Jesus loves to hate on me and some of our information, some of our data until he looks it up, and then he had to do that with this one as well. 2/3 of heart attacks happen in people who have not got 50% blockage. So by definition, a stress test is not going to predict a heart attack. Once you begin to understand what a stress test is, it's looking at two things. Number one, your ability to do exertional activity, your cardiovascular fitness. Fitness is not the same thing as metabolic health. It's not the same thing as cardiovascular risk. The other thing besides fitness that it looks at is plumbing. Whether or not you have plaque blocking over half of your flow. It's a very, very dull indicator of that. And as we said, it's not blockage of flow on a long-term basis, it's an immediate blockage of flow that happens from a clot. Once you begin to understand what causes a heart attack, it's not the plaque slowly closing the artery off. That's just common sense, right? That's what you would think. Sometimes common sense is not what's going on. Sometimes it's not reality. The reality here is that you get what we call inflammation. That inflammation causes a clot, and the clot causes the problem. So that's why that's why this whole thing is built on a house of cards. That's why stress test doesn't work. That's why flow studies don't work. That's why people that have heart attacks are usually not people that have over 50% blockage of their arteries in their heart. It's people that have metabolic disease.
It's not about the size of the plaque.
It's not about size.
It's not about the size. Doesn't matter here, right? All right. What about
Exactly.
calcium score? That goes back to the sizing thing. So what's your opinion on calcium score? I have seen some people saying, well, seems like it's worthless if it doesn't find soft plaque.
Very interesting. You know, I'm finding myself just over the past year changing a significant part of what we talk about. You know, when you do full medical evaluations, like we do every day, one of the things you want for cardiovascular risk, one of the things you want to know about is, okay, do we have plaque? Do we have significant risk as defined by plaque? If you don't have plaque, then there's a whole lot of things that you don't need to be thinking about. One of them is high risk. No matter what your LDL is, you don't need to be thinking about medications like statins. And that's not just me saying that anymore, or some other people like the Bale-Deneen community. That's even the Standards Committee of the American Heart Association. They started saying about 4 years ago, they came our direction and started saying, if you don't have plaque, you don't need a statin, no matter what your cholesterol level is. But things are changing in the imaging world. Calcium score was a great way to look at it, but those of us who work with plaque and understand plaque and cardiovascular risk always understood that calcium's telling you what you really almost don't want to know and not telling you what you really need to know. What do I mean by that? Calcium gives you stable plaque. When your body forms plaque, the way to stabilize it is creating some scarring and creating some calcification. It deposits calcium there. That plaque is just not going to cause heart attack or stroke. It's not going to break off. It's not going to form clots. It's the soft plaque. And unfortunately, calcium score doesn't tell you how much soft plaque you have. And in fact, those of us who do this, when the Standards Committee for the American Heart Association came out and said, okay, you don't need a statin no matter what your LDL level is if you've got a negative calcium score, we all just started to hold our head because they got closer, but they missed it again because what if you've got nothing but soft plaque? Is that possible? Yes, it's possible. And yes, the studies have been done. There are people that have nothing but soft plaque. So be careful how you interpret a calcium score. The other thing that's a little bit, again, outside of common sense, counterintuitive, is the fact that people come to us all the time with these, oh, doc, I'm a dead man walking. I've got a calcium score over 1,000, over 2,000, over 3,000 or 4,000. Jesus did some good work once. He did some good work. He investigated these folks, and he said, "Look, the more you look these folks up in the evidence, in the science, the more these people with these really high calcium scores actually appear to be somebody who's been in bad shape in the past, but has really gotten the message, lost 30 pounds, changed their metabolic health. And these folks are actually more often safe than not." That's exactly what we see. So at the end of the day, what we're doing now is coming up quicker and more emphatically with, yeah, you can do a calcium score. It's easy to get, but it's still not going to tell us soft plaque. There are 2 studies that'll tell us about soft plaque. One's the CIMT, which a lot of people love to hate on, and we can talk about why later. The other is the CT angiogram. And now with CT angiogram with AI analysis, it's a very, very definitive study. Each of those 2 studies does give us soft, inflamed plaque understanding. That's what we need to have.
Yep. And if you see here in the image, that's the image of our heart, and all that white that you see, that it's the calcium that comes from that test. Even I have seen even some cardiologists saying, if you do a baseline calcium score, don't expect that calcium score to go lower as years go by, because they do understand that if you make some lifestyle changes, they're gonna go ahead and calcify and stabilize that plaque. So that means your calcium score is gonna go even higher, and that doesn't necessarily means higher risk. So they do know that.
We actually, we've got a few patients where we've documented lower plaque scores, reversal of plaque. In fact, I'm one of those. And a lot of people look at that. A lot of folks that have been in this space look at it and say that's silliness. No, it's not. One of the folks that most folks in medicine would respect in this space would be the head of cardiology at Harvard. And he said this over 10 years ago on the internet, that yes, we've seen reversal of plaque. From a calcium score perspective, we've seen it as well. I've got a couple of patients that actually, both of them lost like 30 pounds. Both of them had a huge improvement in their metabolic health, and they actually reversed calcium score. As Jesus said, that's not the practical expectation. None of us should go into this thinking, oh, I want to reverse my plaque on CIMT, I want to reverse it on CT angiogram, or that I want to reverse my plaque, my calcium score. That's not practical, but stabilizing it is. Getting your risk back to almost pre-plaque levels is something that all of us can do.
Definitely. What about coronary CT angiogram? I realize some of these tests, well, none of these tests you can do at home. We're going to go to the part of what you can do at home. But this is kind of the best ways to evaluate your plaque and really have an understanding of what's your current cardiovascular risk. So what about coronary CT angiograms?
So, as you know, a lot of folks have been doing CIMT in our community. I've used it for my own health for years. I would have continued using it, but recently I got a CT angiogram with AI analysis. The results are not in yet, and we will provide those when we get them. The bottom line is, we did a video this past year, where we said, it is now the number one way to evaluate plaque, cardiovascular plaque. It gives us pictures that are just fantastic. And it's not just the pictures. There are very clear criteria where we can understand better than ever exactly what type of plaque risk you have for cardiovascular disease and heart attack risk. As I've said a couple of times, the 2 big ways of looking at how you have risk in plaque, soft plaque, inflamed plaque, are CIMT and CT angiogram with AI. Don't get a CT angiogram without AI analysis anymore. The manual reads that a lot of folks are still doing are just not as good. The evidence is very, very clear about that. Now, with the CIMT, it's harder to find a good one, but if you can find one, it's $200 to $400 as opposed to $2,000 to $4,000 for the CT angiogram. It's the CIMT is very for a lot of the CIMT, here's one of the problems. It goes back to that old computer analogy of garbage in, garbage out. A lot of people published work that didn't really know how to do a CIMT, and they sort of poisoned the well. They messed up a lot of the evidence that was there, and standards committees just ignored them for years based on that. They're starting to get good information on it. But again, in the medical world, where $2,000 to $4,000 doesn't mean a whole lot, CT angiogram with AI analysis is just going to take over. It's going to be the standard. What we're ending up doing is describing the pros and cons for each of these two techniques. A lot of people, for example, don't want to get dye, radio opaque dye injected into their veins. So there's several reasons to choose CIMT over CT angiogram, and we go over those with our patients. Even if you get a CT angiogram and you're at lower risk levels, it's not recommended to get another one for usually at least 3 years. It's also a good idea to go ahead and get a CIMT annually in between.
Wonderful. So there's one specific test that people asked us about, and I decided to include it in here. It's called the Metabolic Vulnerability Index, which measures within a specific nuclear magnetic resonance device, measures specific markers like glycase, small HDL particles, and some amino acids. It's basically based on the idea, which has some really good backup behind it, that as you lose muscle and you grow older, your risk of having a heart attack grows higher and higher. More inflammation, less muscle, less protection. Have you seen this before? What do you think about this one, Dr. Brewer?
I'm not too deep into it. I haven't. I don't have a good opinion on it yet.
I personally think it's a good idea, but I mean, it's a new thing that's going out of the blocks. We're not using it yet. I think there's some evidence research that's good to support it, but it's also I think that's still in the works. So if somebody wants to consider this, I don't think it hurts. I think it looks like a good thing. There's one thing that we do use. Oh, go ahead.
We do know that HDL, and especially HDL morphology, is very important. Now, as you and I know, we both look at loss of HDL large is a little bit clearer than small HDL particles, and we look at that every day. We also look at glycated hemoglobin. We look at many other things. When you start looking at branch chain amino acids, yes, there's some significant data behind that as well. So I suspect there's going to be some at least some good evidence supporting the MVX.
Yep, and it is. And just you mentioned glycation, and glycation is just this process where excess glucose tends to mess up with proteins, and glycase is just one marker that measures that level of glycation. So it has to do with that as well. But there's one test we know about more that we use every day, oral glucose tolerance test. What does glucose and the OGTT test has to do with predicting heart attacks, Dr. Brewer?
Well, it's a metabolic disease. You know, as Dave's movie, The Cholesterol Code, showed that doctors forever have been thinking that LDL causes heart attack and stroke. Well, the lean mass hyperresponder evidence is showing that at least in that group, LDL's as high as 700 and more, quote, bad cholesterol, which the standard goal right now is to get it to 70 or less. They're documenting plenty of people with levels 3, 4, 5, and 10 times that amount that are not getting any increase in plaque at all. What does that tell you? Well, there's another thing that we all have known, whether you're Peter Attia or Thomas Dayspring or the cardiologist at the end of the road or again, the other 99.9% of cardiologists and primary care doctors and family practitioners out there who say who think it's cholesterol, none of them argue that metabolic disease is a major cause. We don't argue that either. So that's what we're looking at. Now, a lot of people will say, well, just get the hemoglobin A1C. And again, I think you're going to talk a little bit about why the American Association of Clinical Endocrinologists has said A1C may theoretically sound like a good test for metabolic disease, but it's not. We need to understand how the body manages glucose. And that's what that little bottle of glucola is all about.
Definitely. And just to keep in mind, the oral glucose tolerance test involves going to the lab fasted for 8 hours at least, getting your blood drawn. We recommend getting glucose and insulin levels at fasting. Then they're going to give you that thing to drink, which is the hardest part of the test. It's not fun. After that, 1 hour later, you're going to get your glucose and insulin measured again. And then 1 hour after that, at the 2 hour mark, you're going to get that measured again. And some studies have shown that people who have 200 or more during the test are at a higher risk of having heart attacks and strokes. And that comes back to the diabetes diagnosis. So right now, if you look at the standards will say fasting glucose 126 or more for diabetes diagnosis, or A1C as well as a measurement for the diagnosis of diabetes. The problem is when that's normal, that's not high enough, you might miss a lot of cases with that, especially A1C misses up to 70%, fasting glucose misses up to 50% of diagnosis. And with the glucose tolerance test, you can diagnose up to 90% of cases. So when you see the Framingham, and somebody asked about the Astro Charm calculator for heart attack risk, those calculators ask for diabetes diagnosis. And the problem is there's a lot of people with diabetes that are not being diagnosed. And then you come to the problem as well that if you do have pre-diabetes, you have a lot of risk as well. And that's not being taken into the calculations. That's why this test is so important. You want to know if you do have some glucose metabolism problems or not. All right. What about grip strength?
You know, it's a funny thing about grip strength. Let me ask you this question. Why does grip strength predict healthy longevity?
Well, it comes back again to muscle, how much muscle you have and how functional is your muscle. We like to call that metabolically active muscle. And the way you know that you have metabolically active muscle is by knowing how strong your muscle is. And one easy, quick way to test this with the device that you see on the screen, that device is called a dynamometer. And you can get those like for $20, $30 on Amazon. And it's a way to measure if your muscles are strong enough according to your age. So if you are 75 years or older, you should be able to manage somewhere closer to 27 kilograms if you're a man, 21 kilograms if you're a man, 17 kilograms if you're a woman. And as you're younger, you're supposed to manage more of that. And the way to measure that is with that dynamometer. And there's a lot of evidence showing that people who have weak muscle, that's one of the major risk factors that you want to take a look at as you age in order to know if you're going to have any cardiovascular event or if you're going to have if you're going to fall and break your hip, for example, as well.
So a couple of points. We have that level of, and in fact, I think it's that same hand dynamometer in the kit that we provide for this. We also have a home glucose tolerance test. These are very, very important tests. Do you know, Jesus, why is grip strength, why does it have better evidence behind it than some of the other muscles, like shoulder muscles?
I do not know that. Why is that?
I don't know either. I don't think anybody does. Now, you and I
I,
both
I think I
know.
think it's, I think it's just because it's easier to test, not so much that it has more evidence than other muscle groups.
I wonder if it has to do with the fact that uh, it's so functional. It goes to what you call the homunculus straight. There's
Mhm.
such a good connection to the brain. But you and I also know leg muscle health is critical to managing metabolic health. And in fact, once you reach your mid 60s, up until about the mid 60s, fat is usually a bigger issue in terms of body composition and metabolic health. Once you reach your mid 60s, loss of muscle is a really, really big deal. And many of us would make the case that that leads to more inflammation and more loss of metabolic health than anything else. When you see this quote, cute little old man or cute little old lady, that's not cute. That's dangerous. These folks are on a
Mhm.
fast slide into metabolic dysfunction and cardiovascular risk. So, one of the most important longevity habits you can have is getting those leg muscles working. The leg muscles are the by far the biggest muscle mass in your body, and they are that's where they're your best safety valve against rising blood sugar.
Definitely. And one of the last markers that you want to take a look at is body fat. So you have multiple ways to measure that. You can do the calipers, which Dr. Burr will talk about a little bit later, and you can do also just a magnetic, an MRI, or you can do also a DEXA scan. But the whole point behind it is the more body fat you have, the more you're on that cascade of metabolic disease. And I do want to address something. There's always exceptions to the rule. You will have those relatives or neighbors that you will see people living up to 90 years old, and they will say, well, I always eat poorly, I don't really exercise that much, and they were able to live longer. I will bet that there's not so much people living a lot of years that are actually healthy, but there are some exceptions. That doesn't mean that that applies to everyone. I think most people will find that if they have weak muscles, they have poor glucose metabolism, they have a lot of body fat. These is the people who are going to have a heart attack after 40, under 40s or 50s, and that's what we're trying to avoid here. Any additional comments, Dr. Brewer?
Believe it or not, no.
Well, body fat is important. That's the point.
It's very
And
important. Well, actually, now that you mention it, I always say no, but I got another point. Why is body fat important? It creates insulin resistance. Now, the number one driver for uh, uh, prediabetes, diabetes, metabolic disease is aging. It's loss of function of our insulin receptors. But a large part of that is also associated with loss of muscle mass and, as Jesus was talking about, increasing body fat. Again, body fat creates a hormone called, believe it or not, resistin. And it does exactly what it says. You see, a fat cell, if it gets too big for its artery wall, for its artery, its arterial supply, it can begin to rot within the body. And that's very inflammatory, very dangerous. It's less of a problem than the next problem that it causes. But a fat cell needs to have a shutoff valve to keep it from getting too big for its vascular supply. One thing it does is it creates a hormone called resistin. Resistin says, okay, I know the insulin is coming down because this blood sugar is increasing, but I can't take any more blood sugar in and turn it into fat for storage because I'm just getting too big. So that works for that fat cell. Unfortunately, it works for every other fat cell and every liver cell and every muscle cell. In other words, it makes all those cells that we depend on to pull that sugar out of the blood where it causes inflammation into the cell where it's safe. It creates insulin resistance among every one of those cells.
absolutely. And I'm going to take a few minutes just to talk about the kit that Dr. Brewer put together. So in this kit, you're going to find a grip strength, device, that a dynamometer that's going to help you measure that. Instructions to do on home at home oral glucose tolerance test, body fat measurement and analysis items with calipers, and instructions on an online portal access. So you can get all of this stuff separately. What you're gonna get with this also is, if you get the box, you're gonna get all that orientation kit that comes with it, so you can interpret the results. We have a debut price of $169.50, or if you get additional kits with that first one, maybe to your family members and friends, you're gonna get a special price on $119. So, any additional comments on this, Dr. Brewer, before we go to Q&A? And Gilbert, if you can put the banner in there so people know where they can contact us, you can just call the office or use the QR code or go to the website.
Yep. Again, I can't underline how excited I am, because when you look at provision of services, I came back out of retirement because, I enjoy golf, I enjoy traveling, but, there's that Maslow's hierarchy of needs, and golf and traveling were fun, but I'm not that good at either one of them. And people would criticize my YouTube channel and some of the other work that I do. But on the other hand, a lot of people, as you know, routinely tell us we're saving lives, and there's nothing more fulfilling as a human being than to save other people's lives. And the number one killer right now is metabolic disease. It's something that you don't feel. There are no symptoms. There can be some signs like, obesity, gaining too much weight, having too little muscle. Some signs like decreased heart rate recovery. Just a lot of things that people are just not aware of, but they don't feel on a regular basis. And so for a while, we've been getting more and more positive feedback from the free information that we've provided on the internet with the YouTube channel and the other channels. We've had a lot of people, based on that information, wanted to come in and be seen as full-blown medical patients. But we're expensive to see. And it was either the free information or go all the way up to full-blown medical evaluations. And that's still very fulfilling as well. But at the end of the day, it's been frustrating for me when I see so many people say, I just can't afford that medical care. Is there something more than just the free information? Because I'd like to know, a YouTube video is great, but it doesn't tell me about me, my own body, my own health. What do I need? Where are my problems? What do I need to be looking at? And now we can do that. You don't have to become a full-blown medical patient. You don't need prescriptions. Those are not the most important thing anyway. We've said that from the very beginning. So we're very excited to get this process up and rolling.
Yeah, and being able to create a product that people can use at home, so they can do their own testing and they can analyze their own factors. We know there are a lot of lab markers, and there are some options out there, like measuring fibrinogen or homocysteine, or doing the glucose tolerance test on the lab. But if you're looking to do something that doesn't require you going to the lab, this is a good first step to consider. All right. So, and we also have a link in the comments and in the description of the video if you want to take a look at that. Let's go to Q&A. So first things first, if you want your question to be answered first, please become a YouTube member, a PrepMed channel member, just like Joel, Sybil Wood, and Green Deschamps.
Probably Sybil.
Sybil. Thank you so much. If you want me to butcher your name, remember, I'll be happy to do that.
To butcher the pronunciation?
Oh yeah. That's an extra perk. We also have exclusive YouTube videos every Wednesday that goes to our members. That's not a pay to watch thing. This is people who was already a member and we wanted to give something more. So that's just an extra perk for you. G. Fulton, when a non-smoker checks heart attack risk calculators, how do you account for working in dusty high BOC job? I don't think you do. Is there a calculator that accounts for that? You and I have a background in occupational medicine, Dr. Brewer. So we
Yeah,
know the problem that comes with that.
and it's not quite so much an issue of cardiovascular risk. I mean, there are, as you know, there are ways to evaluate lung risk associated with dust, and as you also know, it depends very, very much on the type of dust.
Mhm.
Some of these very dusty areas that are just cloudy with dust, the dust is so big and heavy, the particles are so big, they don't get down into the lungs. It's more of an upper respiratory thing. Other types of dust, not so much. They can be very dangerous. So it really gets a lot deeper and into microscopic detail about where the risk is coming from. It's with dust. I've given you some time. Have you thought of any other answer you want to give?
As far as I know, there's no calculator that accounts for that.
Not in cardiovascular risk.
No, not at all. But if you do know that you have that risk, it's important that you are aware of that. And as an occupational medicine physician, I have a background on that. I just go ahead and tell people, don't work on these environments if you can't do that. As long as you're working on that, you can have the most protection that you can have. You are just putting yourself at an increased risk of lung disease, and lung disease will lead you to heart attacks and strokes as well, or at least heart failure. So that's a problem, or even cancer, depending on what type of dust you're dealing with. Roger Lamson, when keto 6 months had chest tightness, EKG indicated infarction or in fact infarction. Passed the stress test. 6 weeks later, cardiologist said EKGs often give false results and advise to return to low carb diet. What do you think, Dr. Brewer?
It sounds like he had some chest pain that in the end turned out probably not to be a heart attack.
Yeah, and
that happens all the time.
Yeah, EKGs can give you some data. The electrical function of the heart, the paper itself can give you some data when blood flow is being restricted. So there's a difference between a clogging artery because of plaque or maybe a vasospasm, and both things can give you some images on the EKG. So it's just one test among a lot, and that's why stress tests have a hard time predicting heart attacks. Take IDCR. I wonder if the Bradford-Hill criteria has ever been used to evaluate Framingham for causation. As far as I know, it hasn't. As far as I know, I won't be surprised if there's a paper over there talking about that. And for those who are not aware, Bradford-Hill criteria is a standard that's being used to define if something is causing something, and it has, I believe, it's 7 to 8 criteria, and it's hard to comply with all of those. Like unless you really comply with all of those, you can tell something is causing something. And one of them is the level of association. And a lot of people will just say high association means causation, and that's not necessarily the case. So good point.
So an example is what we call a dose response curve. We talked about it in the studies on retirees, where they saw the stronger the retiree's sense of purpose in life, the longer the retiree lived. And there were multiple gradations of both of those activities, and that's called a dose response curve. That's part of the Bradford-Hill epidemiology criteria for how strong is that association.
Yep. It has to be consistent. The explanation has to be has to make sense. Temporality, the cause, or what you think is the cause of something must come first than the consequence, stuff like that.
And in many ways, LDL it meets a lot of those criteria. It's not that people in medicine have been dumb forever, although we like to think of that sometimes because we get so frustrated that they're not looking at the forest for the trees right now. The LDL has met a lot of the Bradford Hill criteria. It's just that it's breaking apart, especially as you begin to see so many people go on low carb. We didn't have that many people on low carb and keto diets, so we didn't have that many people where LDL was shooting up, even though their health status was improving.
Yeah.
Once you start seeing that sea change, it changes everything.
Definitely. Fox R Truth, thank you so much for your super chat. $9. They go a long way. Thank you so much.
I love that name.
Yeah. Take DCR, DSR. Is there any downside to calcification of plaque, perhaps making it harder to clear out soft plaque? That's a good point. I do think there is a downside of calcifying plaque, but I'll let you answer first.
Yeah, I think all of us rationally have gone through that process of thinking maybe there is a downside. I actually even saw a study once that looked specifically at this, and they actually said they found something different. They said they took plaque out of lab animals, their arteries, and did some things with them. And when they removed the calcium, that the calcium ended up being like mortar and the plaque broke up. At the end of the day, that still didn't prove much in my mind. It did in the researcher's mind because of the filters they were looking at. I'm not going to go further down that bunny hole other than to say nobody knows one way or another on that.
Well, my perspective is a little bit different. I think there are two types of calcification, and it's something I like to call unhealthy versus healthy calcification. And you have there are papers showing that.
Yeah,
when you look at go ahead.
When you look at the anatomic details and locations specifically of that plaque, which you're so very good at.
Well, I'm glad you're acknowledging that I'm good at something. After just beating up on me today.
I hate to admit it, but you're very, very good at that.
So there's something called a spotty calcification, which is when you're just putting dusts or pieces, pinpoints of calcium here and there, and that's kind of a mechanism of survival from your own body when you are on this metabolic health issue storm or metabolic unhealthy issue. With a lot of glucose, a lot of insulin, a lot of inflammation, and your body's trying to react and calcify some of that plaque to make it stable, but it's not able to keep up, and it's just putting plasters of calcium here and there. That will build up a cap above the plaque that is not stable or resistant enough, and that's a problem. And you keep building soft plaque around it. Contrary to people who are doing a lot of exercise, taking care of their metabolic health, allowing their body to heal their own plaque, and you create this cap of not just calcium, but even muscle cells around the plaque that are strong enough, they're thick enough so the plaque doesn't rupture. The downside that I see from that is when you have a lot of soft plaque and you calcify a lot of that, sometimes you have a lot of calcified plaque that can still obstruct the blood flow. So you end up with people with a lot of stable plaque that are having some chest pain, some angina when they're exercising. So that can happen as well. You have a reduction in blood flow. That doesn't mean that you're going to have a heart attack because that plaque is not going to rupture. Still can cause some chest pain. So that can happen. Yeah.
Do you mind if I know you like to do the members, but you also do JMKs as well, because he.
Oh yeah, yeah.
And again, this is a really good question. He said, "Well, wait a minute. Doesn't the FFR measurement done by the AI analysis give the same quote plumbing information as a nuclear stress test? It gives yes, it does give state of the art plumbing information. Again, given what we know, that's not nearly so much what we look at. When we're looking at a Clearly report, we're looking how much non-calcified soft plaque is there. And that's really what we're looking for, the quantity, how much non-calcified soft plaque. And again, Jesus, while you're talking about plaque and soft plaque, you want to translate for me?
Yeah, well, the FFR is the fractional flow reserve. So just meaning how much blood flow comes out after the place where the plaque is, where the obstruction or some of the obstruction might be. And yes, clearly can give you some information about that. The thing is that whenever we look at a Clearly report, we are more interested on the type of plaque, how much soft plaque, or as they label that, low density non-calcified plaque there is. And that's the thing that we look at. Somebody who has 4% or more of low density non-calcified plaque or soft plaque, that's somebody who has a higher risk. Yep.
There you
All right.
go.
John Stoner, do you have a company you recommend to get an oral glucose tolerance test? So if you want to do that on the lab, we use Quest and LabCorp, and the problem is it depends on where you go. If the technician knows about the test, you're not going to have problems. Well, maybe, because sometimes the people who receives the samples, they can mess up as well. So that's the problem with the test as well. There's a lot of hit and miss because lab techs are not used to doing the test, and they can screw it. The test, especially the insulin response, not so much the glucose, but the insulin. They do make mistakes. And if you want to do the glucose tolerance test at home, you can just get the kit from us. That's an option. Or you can get a glucose reader or a CGM. We'd rather you use a finger stick glucometer and maybe do that with some Mott's applesauce, as Dr. Brewer has done in the past.
Mott's applesauce and my home glucose tolerance test demonstration knocked my blood sugar over 200.
Yep.
So if you can get the AI at YouTube to find it for you, go back and take a look.
Yeah, just look for Mott's applesauce, Dr. Brewer, and it's gonna come out. That's from the old shaky paper days. Take out DSR. Did you see that drop on calcium score while taking statin? So which statin and dose? I think he was answering to somebody's comment. There's one interesting question that I'm gonna pop out. Just we're saying maybe not members, but Shaika's Wonderland. We have the tech.
Yeah.
Thank you. We have the tech to attach a camera to an angiogram super thin wire, but we don't have the tech to melt calcification in arteries with regulated temperature controlled steam to melt the calcium. Why would you like to melt the calcium out? What do you think, Dr. Brewer? I know that it sounds like it makes sense to say, well, if I have calcium and I want to take it out, get rid of that plaque, and the problem is solved. What's the problem behind trying to do that?
The underlying assumptions. I saw that too, and I know that you only give me a quota of 1 or 2 non-member questions to put up there, so I chose the other one. But this one is a really good one, and it's like you said, it's the assumption. It's the assumption that, oh, okay, so calcium score, if it's high, it tells me I've got a lot of risk. So what I want to do is get the calcium out of there. That's not the problem. As we discussed earlier, calcium is actually the body's solution, and it's a very good solution. Stable, meaning there's some debate, and I personally don't think that the calcium itself is actually even doing the stabilization, but it's clearly a biomarker that plaque has been stabilized. It's been turned into scar tissue, and it's not going to cause a heart attack. Yep. So, like Jesus has said, why do you want to do that? And in fact, like Jesus, if you go down this road, there are people that would say, well, we can go in there and look and tell exactly which plaque is going to rupture. Well, you can see a little bit of that, but the bottom line is this is not a specific anatomic or plumbing problem. This is a metabolic problem. Once you get that in your head, you begin to realize why stress tests don't work, don't predict heart attacks, because they're a plumbing solution. Stents don't prevent heart attacks because they're a plumbing solution. These things are not metabolic solutions. And yes, you may say, okay, well, maybe the cabbage, the bypass graft is going to prevent the heart attack. No, just go find the number of people that have tried to use that as a solution. It's a plumbing solution. This is not a plumbing problem.
So let me try to exemplify something. Give you an example. So imagine we have something that does that, right? And stents are probably the closest thing we have for that. You have a plaque in there. They tell you, I'm gonna go there and put a stent on it and open the vessel up, so you have no more plaque to worry about and problem solved, right? So you're off the hook. The problem is, as Dr. Brewer said, this is a metabolic problem. This is not just a plumbing problem. So this is your heart. Let's see if the camera can focus on this.
There
There.
you go.
So all the red lines you see, this red line over here is the right coronary artery. This red line over here is the left anterior descending, also called the widowmaker, which is a branch of the left coronary artery. And this is the circumflex artery. And as you can see there, they have a lot of branches on them. It's not just those three main ones. There are small branches here and there that you will see in multiple places on your heart. And these are very, very small vessels, right? Guess you have one plaque in there, they put a stent on them, and they tell you you're fine. And you keep up eating McDonald's, being a couch potato, and all that stuff. Then you have a heart attack because a plaque that they didn't notice it was big enough, or it wasn't big enough, but it was soft plaque, rupture in another vessels where they did not put a stent on. And even if you put a stent on one, there's a lot of cases of something called restenosis, where you build plaque above the stent or within the stent, where the place where the stent was. So that's the problem with a solution like that. We would love for a solution like that to work, but at the end of the day, you cannot escape the lifestyle change that you need to do. There's just no way to escape that.
You know, industry has engineers in industry have figured out a lot of things that we haven't quite figured out in most medical groups yet. One of them has to do with root cause. This is a root cause issue. It's not the problem that's right in front of your face. It's sort of like saying, okay, I keep getting junk in my plumbing in my house, and the problem is there's a tree that has gotten into the roots of the tree have gotten into your source out in your yard before the pipes even get to your house, and it keeps dumping dirt into your plumbing, and you keep repairing your plumbing in your commode and your plumbing in your sink and your plumbing in your shower. You got to get back out to the root cause, the place where that dirt is getting dropped into your plumbing in the first place. And here it's the metabolism. That's the source.
Yep. I want to address two comments more, and that's it. Mooney Eye Sidox. I don't think we can send the kid to Sweden, can we?
We need to ask. I'm not so sure that we can't,
Okay.
but we'll see.
Well, we're going to ask Moon Eye.
And actually, if you'll put the banner up to show the answer email.
Yeah. Gilbert, can you
Will you
put
do
that
that?
over, please? This is what you're talking about, Dr. Brewer?
No, there's an email that you can ask. It's what is it?
Info@prevmedhealth.com.
Info@prevmedhealth.com.
I don't know if we have a banner with that. Gilbert, if we have a banner with that, please put it up.
There was also the telephone number.
Yeah, or just the telephone number or the email, the website. Yep.
859-721-1414 or info. Oh, that's good. Just show that scan, that QR code on the right.
Yep. All right. Donald Davison, does a calcium score actually drop with improved metabolic health, or is it basically a static once it's in place, since essentially, as I understand, it's a sign of the body putting a bandage on our artery wall? I like that analogy, a bandage. Well, it depends. I think it. Oh, man.
Oh, did I? What did I just hear you say?
I hate to say it, but it depends. Come on. So if you have a lot of soft plaque when you're starting your lifestyle changes, you should expect your calcium score to increase. That means you are healing that artery. You're decreasing that goo, that inflammation, and your body is going to create some calcium over that. Yeah.
And there clearly is a scarring process. And, some people reverse scars sometimes. Most don't.
Yep. Yeah. Yeah, and it might happen. I would not be surprised that you still build up some calcium. What you can expect is that your calcium score doesn't go up as fast, as quickly as it would if you're not doing any lifestyle changes. And the other thing, I think also there's some people that if they have a very poor lifestyle, they won't even notice a calcium score going up. They're going to have a heart attack before that. So you will not even know. All right. So that's the show for today. Thank you so much for joining us. It was a little bit of a longer show. We're going to be talking about sleep next week. And we're hoping to be able to post a video this Saturday about nitric oxide. So don't miss on that one either. Any closing remarks, Dr. Brewer?
So you failed miserably again in keeping it. It's your job to keep us at less than an hour.
You were doing so good when you were saying that I was doing good stuff.
Yeah.
Thank you, Mar, for
becoming a member.
You might not realize, but it goes a long way. Thank you so much.
It really does.
All right. Well, see you next week, guys.
Bye-bye.